Right, hopefully that's all sharing screen correctly. Thumbs up from Ben, great, thanks. Hi everyone, and thanks Ben for the chance to present this research today. I am presenting, I guess, on behalf of quite a wide team that contributed to this, but really I'm presenting work that was led by Alex Richards, who I've seen is on the call. So actually, if you ask any difficult technical questions, I may direct them her way. But really glad to have the chance to present this work to you today. This is some work that we've done recently through the LIGHT Consortium. For those who aren't familiar with LIGHT, this is a 6-year cross-disciplinary global health research program that's funded by UK Aid. It consists of 7 different partners across the UK, Kenya, Malawi, Nigeria, and Uganda. And the overall aim of LIGHT is to support policy and practice in transforming gendered pathways to health for people with TB in urban settings. So working in a variety of different areas within these countries, but thinking all about gender and TB, and what we can do to address some of the disparities that exist. The modeling components of LIGHT are led by our team at LSHTM. And as I mentioned, this work I'm presenting today was led by Alex Richards. So just want to acknowledge that. Now, to start, first of all, why are we talking about men? Just to give a bit of background, we know that gender is a core social determinant of health. We know that it interacts with biological sex and with other identities and characteristics to impact all aspects of health, from thinking about risks and recognition of disease, and experience of disease, to access to care and experiences of care, all the way through to recoveries and outcomes. And that's true for general health. It's also very true of TB. We know that gender is a key social determinant of TB. Just to give a bit of background of how we got to the point we're at today, if we look at case notification data, we see that notifications have been higher among men than women since the WHO began reporting these data. Last year, the male to female ratio in global case notifications was 1.6 to 1. And for a long time, there was an assumption that these higher case notifications among men were the result of underdiagnosis of TB in women because of women's disadvantages in accessing TB diagnosis and treatment. However, TB prevalence surveys have shown us otherwise. So the scale up of national TB surveys since 2007, I've shown here that figure from WHO's Global TB report, shows that male to female ratios in bacteriologically confirmed adult TB are consistently greater than 1 in these surveys. We published a systematic review and meta-analysis almost a decade ago now that looked at both national and subnational surveys conducted in low and middle income countries. And we found an overall male to female ratio in prevalence of 2.2 to 1 for bacteriologically confirmed TB. And so what that indicates is really that about 70% of undiagnosed infectious TB occurs among men, despite adult men accounting for only 37% of the global population. Now, why is this? If we want to understand the reasons for higher prevalence among men, we need to remember that prevalence is a product of incidence and duration. And our previous modeling work suggests that both these things are higher among men than women. And this is supported by several other pieces of data as well. I've just shown a couple here. If we look at this figure on the left, when we think about incidence, these are results from a recent systematic review by Hannah Rickman that shows a higher annual risk of MTB immunoreactivity conversion among men than women from adolescence. And then the figure at the bottom shows WHO estimates of global disease incidence in gray. And those bars you'll see are higher among men than women, again, from adolescence. If we then think about duration, there's a couple indicators that give us a sense of duration because we found that duration's a really tough thing to measure, right? If we just look at self-reports, then we're missing those individuals who don't access care often. But we also find biases, particularly as we recognize that individuals may undulate or fluctuate in their symptom presentation across the course of disease. But looking here, if you look again at that figure from WHO at the bottom that shows incidence and case notifications, you'll see treatment coverage is higher among women than men. So those gaps, those gray gaps in case detection are larger for men, again, from the time of adolescence. And then on the right, going back to prevalence surveys, this figure shows the prevalence to notification ratio for men and women, men in orange and women in purple. And you'll see that those values are higher for men in most surveys, not every setting, but in most settings. I'd like to touch briefly on some of the explanations for these differences between the sexes. And we've conceptualized these using an adaptation of the Dahlgren and Whitehead rainbow model of health determinants. If we sort of start at the center here, there's evidence of biological factors that likely contribute to these differences, namely genetic predisposition and differences in immune response. If we then consider behavioral factors, this would include risks like alcohol consumption and tobacco use, both of which we know are associated with higher risk of TB infection and/or disease. And I've shown those data here from our world in data, just highlighting how consistently higher among men than women these factors are. We could also think about things like other behaviors like substance use, comorbidities, such as chronic respiratory disease, and also HIV, which I will note, we do know that prevalence of HIV is higher among women relative to men, but incidence is actually now higher among men, and we see that men are less likely to access ART, and those who do access ART do so at a later stage of disease. So I think that's a risk here. At a social level, factors like social contact patterns, mobility, support networks, and stigma may contribute. I've shown here data from a systematic review of sex-assortative mixing. And I would just highlight that when we look at mixing patterns, if we look at children's contacts with adults, we see that both boys and girls preferentially mix with women in their adult contexts. But if we then look at adults, we see that adult men preferentially mix with other men, while adult women preferentially mix with other women. And so there's an opportunity to amplify transmission here among men. There's various structural and institutional factors that likely contribute. Men often cite occupation, both in terms of occupational risks, but also thinking about the lack of social protections in many environments as being key factors in their decisions to access or not to access care. Also thinking about migration patterns, both within countries and between countries. Prison facilities, as imprisonment levels of incarceration are much higher among men than women. And then health services and how those health services are structured and may have better reach among one sex than the other, particularly among women. And then finally, we just find these overarching roles of gender norms and expectations that increase men's risk of disease, but also limit their access to care. So here, qualitative research has highlighted factors like expectations of physical strength, stoicism, control, how these things conflict with admission of illness, but then also expectations to fulfill roles as leaders and providers. And that links back to occupations and social protections and how this often leads men to deprioritize their healthcare needs over more immediate concerns. So this just gives kind of a broad context with which we approach this work and why we feel it's important. If we then look at the specific country context where we've done this modeling, I mentioned previously that we're working in Kenya, Malawi, Nigeria, and Uganda. And here I've extracted the sex disaggregated data on prevalence and prevalence to notification ratios from the Global TB report. And I would just highlight a couple of the differences that we see across these settings. These are all sub-Saharan African settings, but there are important differences when we think about gender or sex and TB in these settings. So thinking about prevalence, you can see the male to female ratio in prevalence is extremely high in Uganda. More in line with what we see as global estimates in Nigeria and Kenya, and a bit lower in Malawi. If we then look at prevalence to notification ratios, you can see really high ratios in Nigeria, also with a large gap between men and women. And in Uganda, overall, the estimate is lower, but still with a really large gap between men and women. So within these contexts, and after much discussion with our colleagues across the LIGHT Consortium, we mapped out 3 key questions for our modeling work that I'll be sharing today. So we're looking at the potential epidemiological impact, first, of increasing treatment coverage among men, second, at reducing men's excess risk of TB, and then third, doing those 2 things together. So we conducted our analysis using a model that has TB, age, sex, and HIV-ART structures. Our TB model was derived from the time model, which many of you may be familiar with. But given the evolving understanding of TB natural history, we shifted from an approach that distinguished smear negative and smear positive disease to focus on asymptomatic and symptomatic disease. And we updated our model parameterization accordingly. Now, in terms of sex and gender, since that's our focus, I thought I'd spend a minute just commenting on how we incorporated sex and gender differences within this model. So we do use sex-specific demographic data on births, deaths, and migration. Also sex-specific data and inputs on HIV incidence and ART initiation. We then do recognize mixing by both age and sex, acknowledging those different patterns among children compared to adults. To do this, we referred back to the systematic review that I mentioned that gives data on a number of countries, but we also updated that review and looked for more recent studies from the African region. So for a couple of the countries we modeled, we were able to use data from those countries. For others, we did a meta-analysis of the different social contact surveys that have been conducted in the African region and used an overall estimate for the region. We incorporated a relative risk of infection attributable to sex or gender-based risks. We didn't define these risks specifically, so we didn't look at specific rates of smoking or alcohol consumption, for example, across these countries, but we incorporated a generic risk to account for these. And then in terms of relative access to TB treatment, our model uses a very simple approach to diagnosis and treatment. There's no detailed diagnostic pathway or care cascade. So we have a single term for access to treatment, and then we use WHO data to inform treatment success or treatment completion data from that point. So this single term that we use encompasses access to care, utilization, diagnosis, and treatment initiation. So we don't recognize lost follow-up at each of those stages. I do want to comment a little bit more on this term in our model, though, because I think it's one that's often challenging to parameterize because we don't have great data on it. So the time trends that we use are loosely based off treatment coverage with an assumption that there will be continued improvements in access to treatment in the future. We defined a base value and then scaled that based on age, ART status, symptoms, and sex. And there's a hierarchy in those scales, so we weren't trying to set a different value for each of those things, each of those interactions. I'll also mention that for Uganda, we made some further adjustments to account for the CAST program. For those of you who don't know CAST, it's a community awareness screening and treatment approach that's been implemented in Uganda since 2022. And they're doing twice annual community screening. And just to give you a sense of the scale of this, in the first campaign, which was conducted over 5 days in early 2022, They screened 3% of the country's population. Then in the second campaign later that year, they screened 11.5% of the country's population. So we also incorporated an additional scalar from 2022 to reflect the impact of this program. We calibrated the model to country-specific indicators for each of the 4 countries, including prevalence, incidence, mortality, and notifications, with disaggregation by age, sex, and HIV status where the data allowed. And we used a history matching and emulation algorithm, HMER, in R to identify 1,000 parameter sets that were consistent with calibration targets for each country. I won't show all 4 countries just in the interest of not being too repetitive with the slides that I show you, but this is an example from Kenya. You'll see prevalence in the top row, then incidence, mortality, and notifications, and some ratios at the bottom, prevalence to notification ratios for men and women, and prevalence ratios, male to female prevalence ratios. And then the columns show overall values, men, women, children, and HIV positive individuals. So we then implemented strategies to answer our research questions. When we were looking at increasing treatment coverage, the specific approach that we took was to increase access to treatment among men to the level that's been achieved among women. We obviously could have chosen a number of different approaches here or levels, but we went with the approach that NTPs have achieved a certain level of treatment coverage among women, and that has been feasible. And so let's see if they were to reach that level of coverage among men, what impact that would have. The second one was to reduce men's access to risk of MTB infection, this term that I mentioned, relative to women by 50%. And we had some sensitivity analyses that looked at reducing that by 25 to 75%. We did not go all the way to 100%, recognizing that there's likely biological factors and other social and cultural and structural factors that would be difficult, if not impossible, to eliminate. And we scaled up each of these strategies with a sigmoidal approach from 2025 over 5 years. Now, I say we assess the potential epidemiological impact. We did this by considering impact on incidence and mortality in 2035, also episodes and deaths averted by that year, all relative to a baseline scenario that overall considers status quo from 2025, sorry, 2024, but does recognize continued improvements in access to TB treatment over time. And we considered both population level impact, but also disaggregating impact for men, women, and children within the population. So if we look at some results, thinking first about treatment coverage shown here in blue, this is the percentage reduction in incidence by 2035 from each of these approaches. So treatment coverage, we found the reduction in incidence ranged from 5% in Malawi to 25% in Uganda. While that value is highest in Uganda, I think it's important to note that this approach in Nigeria averted 35,000 deaths over this time period. So it's also notable to take into account the population size difference in these countries when thinking about the absolute magnitude of these impacts. If we consider risk reduction here, we found the greatest impact in Kenya and Uganda with 20 and 23% reductions in incidence, respectively. And that compares to Malawi and Nigeria, where reductions were about 8 to 9%. Now, interestingly, when we look at deaths averted, there's a shift between the countries. So we actually found more deaths averted in Kenya and Malawi from this approach relative to the previous one, but less in Uganda and Nigeria relative to improvements in treatment coverage. And then we also looked at the combined impact of these. So again, greatest impact in Uganda, heavily driven by, by having high impacts of both in independent approaches. So that's about a 37% reduction in incidence, followed by Kenya with 25%, Nigeria 22%, and Malawi 13%. Now, we did disaggregate these impacts by age and sex as well. And so as you can see here, so these are impacts for men. Apologies, this is a little bit blurry. And as you would expect, substantial impacts among men, because these are strategies that directly address the burden of disease in men. But I think it's also important to note that we do see some improvement, some reduction in incidence among women as well, despite none of these strategies directly reaching women, and actually a slightly greater impact than we see among women, among children, which really highlights the population level impact of the burden of disease among men and the opportunity to see improvements across age and sex just by addressing this burden of disease in men. Now, we are aware that this very much comes at a cost. The interventions that we examined here were extremely generic, as you've seen, and so we weren't able to quantify any implementation cost. But we did look at the impact of each strategy on case notifications relative to that baseline scenario that I mentioned that we've used for all our comparisons. And I think what this figure nicely shows is how the approaches that increase treatment coverage require additional health systems capacity. And it gives an idea of to what extent that capacity is needed. So in Uganda, we see up to a 20% increase in notifications by 2027 or 2028, which is quite substantial. But I think it's notable that within about 7 years of the start of the implementation of each of these strategies, there's been an impact on disease burden to such an extent that now there's actually fewer notifications than the baseline scenario. And so it just highlights the need for that upfront investment in time and resources. I think our conclusions here are fairly straightforward. Increasing treatment coverage among men, reducing men's excess burden of TB are likely to reduce burden across the population. But it is notable that the relative impact of each of these strategies does depend very much on the context in which they're implemented. And so while one setting, it might be most appropriate to invest resources in increasing treatment coverage, and another, it might be more effective to look at reducing different risks or different determinants that drive the burden of disease. Ideally, we would do all of them, but of course, resources and time are limited. But how do we do this? And I think this is a big question. So how do we increase treatment coverage among men? Just a very rough analysis of a few different studies shows, very low presentation of men to primary health facilities. If we go door to door, you see slightly higher proportion of men who are reached, community-based even a bit higher. But what we hear over and over again is that we need to meet men where they are. And there's a question about where that is. There have been a number of different programmatic approaches and some studies that have looked at how we can actually reach men. So thinking about workplaces, here you can see fisher communities in Uganda, miners, transport settings in Nigeria. Has been one approach, is to meet men who are employed, but that does only reach men who do have employment or who are spending their time in those places. Another approach is to actually develop male-friendly health services, and that's these two pictures in the middle, the van and a clinic. So this is a van in South Africa and a clinic in Lesotho that are men-only clinics. They're open after normal operating hours. They're staffed by male healthcare providers, and they've seen some success in reaching men for TB and HIV and other health concerns. And then one of these clinics, I think it's the one in South Africa, often sets up at a transport hub. And that's another thing that it's been suggested could be beneficial, is by going into these settings where men may be passing through or maybe congregating. And that's something else that we're looking at within the Light Consortium right now. Our work in Nigeria is looking at meeting men where they are in communities, in social and congregate settings. Another thought is to think about other healthcare facilities that may not traditionally conduct TB screening. And we're doing some work on this in Uganda, looking at whether we can incorporate TB screening there to reach men where there's higher attendance by men than we see in primary care facilities. On the second point of how do we reduce men's excess risk of TB, it's complex given the number of factors that can contribute here, and particularly given most of these factors are not really within the scope of the national TB program to address. And I think this is where the need for a multi-sectoral approach is needed. And this is a figure sort of highlighting the intersections of these different vulnerabilities and different risks. And I think it will require working with other health programs to reduce, say, reduce smoking, find ways to support reduced alcohol consumption, but that also has economic and other implications. And so we'll need a much broader support within a government. However, I think this is something we need to do. So this is from the draft. Sorry, I should have updated this to the final political declaration from the last UNHLM on TB, really acknowledging that the epidemic is driven by both health and social and economic determinants. And this lists a number of specific factors, most of which are actually predominantly among men. And so I think we need to address these things. We need to recognize that an effective and gender equitable response to TB is going to require that we find ways to address the inequalities that exist. And hopefully our modeling contributes a bit to show that that will have benefits across the population. As I close, I just want to acknowledge all the co-authors on this work. Also, all of our NTP collaborators who have given us fantastic feedback throughout this work. They gave us a lot of comments and feedback from the early days of defining our research questions, but through to looking at our calibrations and pointing out whether, what they thought of the trends that we were seeing. And so it's been a very iterative process with them. I'll acknowledge all the partners of the Light Consortium, as well as the TB Center and TB Modeling Group at LSHTM. Here's a QR code if you're interested in reading the preprint that is up on this work. And thank you all for listening.
Fantastic. Thank you so much, Katherine. That's really, really interesting piece of work. Thank you. Does anyone have any questions? I think maybe I can, Nick, do you want to start us off?
Okay, yeah, I have two questions. And so for the first one, which is a more scientific question, so we've been doing modeling on efforts to reduce racial ethnic disparities in TB in the US. And one thing that has come out of those modeling studies is that, it's easy to run interventions that decrease population level incidence, but actually to achieve a reduction in kind of relative disparities is hard, that the benefits from one group are, and in a good way, shared by the other groups. I saw that you, as compared to what we did, you were actually were able to achieve much better or bigger reductions within men as compared to the other groups you looked at, women and children. I was wondering if you could speak to, what particular elements of the interventions you looked at kind of led to that.
Thanks, Nick. Thinking about the model implementation of our interventions, we probably simplified things by really having reach that only reached men for each of those interventions. So in the real world, if you were doing community screening, even in these places where you're likely to reach more men, you're likely to also reach women, and others within the population. So I suspect that in reality, you might see a more diluted effect there. I don't know if, I mean, a lot of our estimates on impact in women and children are driven by the social contact data that we use, right? And thinking about how reductions among men then translate into onward transmission to other groups. I don't know if there are, if we make stronger assumptions about preferential mixing than you would see in the work you've done, and therefore we don't see as diluted of an impact. Not sure, but those are the two things that come to mind.
Yeah, that makes sense. And I've got another question, but after Finn.
No, that's all right. Go for it, thank you.
Okay, well, this is a deliberately provocative question that goes outside of the scientific material. So I'm wondering why we should focus on TB amongst men above and beyond other priorities.
Well, I had an answer for you until you said above other priorities. And then I think there's a question of prioritization, right? Um, why should we focus on TB among men? I think there's two very clear answers. One is that purely from an equity standpoint, it's the right thing to do. This is a group that has a high burden, low access, relatively low access to care. And so it is inequitable that we are not doing more to reach them. I suspect to also be controversial that if it was a different group, we might see more work being done to reach this group. If there were another demographic that had similar level of disease and relative burden of disease and limited access to care. And secondly, because it has an impact on the burden of disease, right? It's a high burden group. They're not getting diagnosed and treated, and so they are continuing to contribute to transmission dynamics within the population. And we're doing some work now trying to quantify that. And it does seem like, the vast majority of transmission is attributable to contact with men. And so whether you're thinking at an individual level or at a population level, I think it's something we need to address. Now, getting to the question of should we focus on men or should we focus on vaccine development, I don't know. But for example, vaccines, but
yeah, and the efficiency argument of it, as in like if targeting men is more efficient because they are higher burden group and they do transmit to others, I think that's obvious. And so or I accept that. And I must say I'm raising this not because I've got a dog in the fight, but I think it's useful to know just how we're conceptualizing stuff and the motivations. And so one could argue that for a lot of other conditions, it's sort of the other way round. And so if we're thinking about equity, if we think about equity condition by condition and sort of resolving inequalities condition by condition, we might get a different distribution of services than if we think about equity in, a broader definition like health or even just infectious diseases. And that second one might lead to overall, higher sort of health attainment, I guess, if we weren't kind of salami slicing how we thought about equity. Yeah, and so that's the motivation for the question, more just as for discussion rather than, again, to push a particular position.
no, I think it's a fair point. I do, but and I would, without underlying solid evidence, I do feel strongly that the issues that are driving the high burden of disease in men and a lot of that inequity of that disadvantages men in TB is actually just the flip side of the same coin that drives other gender inequities that we see in society and health and whatever else. And if we really wanted to address all of this, I suspect some gender transformative approaches and shifting systems around for general equity could potentially have an impact, but those are very complex things to try to address or quantify.
Yeah, but point well taken. So fair enough. Thank you.
My question was actually similar to Nick's, but possibly slightly less controversial in that I was thinking about the prioritization component and wondering if you had plans to do any sort of cost effectiveness or anything, particularly thinking about the I feel like the treatment coverage stuff, as you said when you were describing them, is a lot easier to conceptualize how you might weigh that up, whereas the second round risk reduction must be a very difficult thing to work out how we prioritize different components of that. And is there anything ongoing in that regard that you know of?
Yes, I think on the first point, thinking about, it sort of fits into the broader discussions around community screening and active case finding and that type of thing. And we are now thinking about, can we model some of these approaches that we've been looking at in light within countries, and with that, we could potentially look at some proper cost effectiveness analysis and, try to link some more specific modeling into the work that we've been doing in some of these countries. The second part is really complex. We did some work in Vietnam where we tried to attribute TB risk among men to, say, alcohol and tobacco smoking. But then, of course, there's a million other factors that also come into play. Also, we don't have good data on the intersection of these different risks, right? We could say this much of the population smokes, this much drinks, for example, but we don't have a good sense of the overlap between those groups and the overlap of risk, how that affects individuals' risk. So I think it's really complex to try to do.
Yeah, absolutely. I can't imagine where you start with it. And is there, I guess, so you're doing this as part of the LIFE consortium, sort of thinking through some of these things and generating evidence and so on. Do you think it's likely, also possibly a difficult question, but do you think it's likely in the current funding landscape that interest in this will continue and countries will actually take this up? Or do you think everybody's going to be scrabbling for just maintaining what they've got going on in current programmatic activities?
Like a fairly clear response. I think I think at the moment, a lot of countries are scrambling to recover from these drastic funding changes that have just come into play. Within Light, certainly, we have been working really closely with NTPs in each of these countries. And so as I think I referenced, ongoing discussions from the early days of the work through to now as we start to, get some results and things. And certainly in these countries, there is real recognition that this is a problem. There's definitely buy-in at the national level, and some actions being taken, but the funding landscape is another issue. And certainly a lot of funding within TB around gender is still very much linked to women's empowerment, as it should be, in many ways. But it's a challenge when you see that you have, say, a high burden of disease in men, but a lot of funding is related to gender, is tied to women and girls. It's all needed. I mean, if we could just have more funding, that would be great.
Yeah, thank you. Peter, do you want to ask a question?
Yeah, thanks, Katherine. Great presentation. You just stimulated a thought when you were talking about the different levels of healthcare, and just do you have a gut feeling for how interventions targeted at men within the health centers or hospitals, what sort of epidemiological impact that might have? I.e., they often cost a lot of money, and are they worth doing?
Just to make sure I understood, Peter, you mean like interventions within that existing healthcare facilities?
Exactly. Yeah. So, limited budget. Should you spend it on community-based case finding or rather spend your money in clinics?
Well, I think you know as well as anyone that certainly within primary care facilities, the number of men who attend is really low. We haven't looked at whether increasing screening opportunities for those men who do attend facilities would help, but I sort of thinking about the different risks and different determinants that come into play, I would sort of think that a lot of men who are at high risk of TB may not be the ones always attending clinics. I don't know. I think it's a fair question of what's the most efficient approach. I'm not sure.
Thanks.
Can I ask, I mean, I'm not sure about I was thinking about so you have the risk reduction component and the increasing coverage component. For risk reduction, a lot of, when we think particularly about things like preventive therapy, those are often, like a preventive therapy at least, is a household focused intervention in a lot of settings, or that's what we're aiming at. Is that potentially an issue because you have men who have TB, so it will be household contacts who will be women and children. So is it that our preventive, some of our preventive strategies are kind of focused on what more likely to be women and children and sort of exacerbating? I mean, I don't know what else we do because we do that because those are high risk groups. But is there anything we can do about that? Is that okay, I wouldn't want to, I wouldn't want to say we should stop doing that, but are there ways that we can focus just on the TB component of the risk reduction?
Yeah, I don't think we would stop. I mean, I think it's just sort of by nature that if most of your diagnoses of TB are among men, then yes, you'll be giving more preventive treatment to women and children, as you say, as you should be. You could maybe consider a broader I don't know what you would do. You could consider a broader reach of contacts outside the household, but we target households because we know that there's particularly high risk there.
Yeah, I didn't have a solution. Thank you. There's also a question from Cesar. I don't know if you want to unmute and ask that.
Hello.
Hi, yes.
Hi, Cesar.
Sorry, very interesting presentation. I was wondering because we are exploring similar questions in this region in South America and Peru. And one of the things we are exploring is the role of masculinity and also machismo that can affect also access to care, especially in young adults. I don't know if you have some ideas about it.
I do have ideas. I mean, I think a lot of this is driven by cultural norms around masculinities. Interestingly, we have just done some analysis in Malawi looking at, within a prevalence survey that was done in Malawi, they collected a scale of perceptions of gender equity. And we've just done an analysis comparing perceptions of gender equity to TB testing history. What was quite interesting in that is that actually we found that those with the most inequitable gender views were slightly more likely to have previously tested for TB. Now you could argue, it opens more questions than it gives answers. But is that because those individuals have engaged in more risk behavior that has led them to be more likely to have TB or whatnot? Lots of questions there, but I do think that these cultural expectations, cultural norms, likely play a huge role. When you look at these sort of different risks and things that I presented, a lot of that is driven by masculinities and gender roles and all of that. As I said to Nick a minute ago, I think it's kind of a flip coin of a lot of the gender issues that we see. This is just an area where we see a disadvantage for men coming out of it.
Thank you. Are there any last questions for Katherine then? All right, and if not, James, go for it.
Thanks. Thank you for the interesting talk, Katherine. I was wondering, I know one of the factors you mentioned is like the fact that there's potentially different immune responses between sort of men and women with regards to TB. Of course, there does seem to be some evidence that like the immune response and genetics do seem to have some impact. I was wondering, are you considering looking in terms from a modelling point of view? I appreciate your model at the minute is a sort of betweenist epidemiological approach. Is there any thought of potentially doing future modelling across multiple scales, which would perhaps factor in potential differences like changes in the immune response, for example, or other sort of lower scale factors beyond the wider population level?
Really interesting question. I'm a little bit outside my expertise when it comes to the biological side of things, if I'm completely honest. So don't have any plans to expand here. Yeah, I think it'd be really interesting if someone knew a bit more about that area than me to guide that work.
Great, thank you.
Thanks, James. Any other questions for Katherine? And all right, thank you very much. Thank you again, Katherine, for a really interesting talk. It's definitely sparked lots of discussion. We have another TVMax seminar, just to let you know, coming up on the 19th of June, which is in fact going to be from Nick, so we can flip it around and we can grill Nick with difficult questions in a month's time if you want to join us. But yeah, thank you again, Katherine, and thank you everyone for joining, and look forward to seeing you next month.
Thanks very much.